So here, just a brief introduction. Am I audible? Oxygen is a chemical element with symbol O and atomic number 8. It is a highly reactive non-metallic element and oxidizing agent. O2 or the dioxygen is the most stable form of oxygen. So some of the characteristics of this oxygen is as we all know, it is a colorless, odorless, tasteless, non-inflammable, and which accelerates combustion, and that it condenses to liquid at minus 182.9 degrees centigrade and freezes to solid at minus 218 degrees centigrade. And atmospheric air contains, as we all know, 21% of oxygen. So just a brief history. In 1774, Joseph Priestley discovered the element of oxygen, and in 1783, French physician Dr. Kavitha first time used oxygen therapy as a remedial measure in disease. And in 1878, Paul Bert discovered the oxygen toxicity. So why do we all need oxygen? As we all know, it is required for the regulation of breathing process, for metabolic processes, and 90% of our energy comes from oxygen, and also for most of the phagocytosis which takes place in our body, assimilation of nutrients, elimination of metabolic waste, maintain a strong immune system, and for concentration, alertness, and memory. So here we'll just talk about the oxygen transport in our body. So oxygen enters into the blood from the alveoli by simple mechanism of diffusion, and in the blood oxygen is transported in two forms, as we all know, dissolved state, which constitutes about 3%, and oxyhemoglobin, which constitutes 97%. From the blood, oxygen enters into the tissue due to pressure gradient. So the most common oxyhemoglobin dissociation curve, it is nothing but a relationship between the amount of oxygen dissolved in the blood and the amount attached to the hemoglobin. This is called the normal oxyhemoglobin dissociation curve. So we all know that this is a normal oxyhemoglobin dissociation curve. So we know that there can be a shift to the right or to the left. So some of the causes for shift to the left of the oxyhemoglobin dissociation curve are like increase in the pH, decrease in the carbon dioxide, 2,3 dpg, or in decrease in temperature or hypothermia. So examples are like stored blood. The blood which is stored loses the 2,3 dpg, and this causes a shift to the left, and then hyperventilation or hypothermia. So shift to the right occurs when there is a decrease in pH, increase in the which is opposite to the shift to, which occurs opposite to the shift to left. So increase in carbon dioxide in 2,3 dpg or in temperature. Examples are hypoventilation, fever, and metabolic acidosis. So oxygen therapy, so oxygen is used as a therapy. So it is usually defined as administration of oxygen at concentrations greater than those found in the ambient air, that is requiring more than 21%. And the purpose of oxygen therapy is to achieve adequate tissue oxygenation using the lowest possible FiO2, which is our goal of this session. So the goals of oxygen therapy is, we all know, to treat hypoxemia, decreasing the work of breathing, and decreasing the myocardial work. So oxygen saturation is a relative measure of the amount of oxygen that is dissolved or carried in a given medium. So we all know there are certain terms like SpO2, SaO2, PaO2 where we use in our day-to-day practice. So we'll just go through what it is. SpO2, oxygen saturation as measured by the pulse oximeter. So, and SaO2 is the oxygen saturation as measured by the blood analysis, that is the ABG, and the degree to which the oxygen is bound to hemoglobin. PaO2 is a measurement of the partial pressure of oxygen dissolved in the plasma, and it is measured in millimeters of mercury. It is not the body's total oxygen content, but it does indicate how much oxygen is available in the alveoli to dissolve in the blood. So these are the common terms we use in our practice. Hypoxia, what is hypoxia? It is an abnormally low oxygen content in any tissue or organ or the whole body as a whole. And hypoxemia is usually defined in terms of reduced partial pressure of oxygen in arterial blood, but also in terms of reduced content of oxygen or percentage of saturation of hemoglobin with oxygen, which is either found singly or in combination. And hyperoxia, as we all know, occurs when the tissues or the organs are exposed to an excess supply of oxygen or higher than the normal partial pressure of oxygen. So coming to some of the pathology of the oxygen. So here pro-oxidants include oxygen radicals or reactive oxygen species, which can be cytotoxic because of their ability to alter the cellular components and function. So the reactive oxygen species are generated as a result of normal mitochondrial respiration, reperfusion phase of hypoxic tissue injury, infection, and inflammation. So oxygen is called toxic or becomes toxic because of the production of reactive oxygen species. Thus, oxygen administration increases the oxidative stress. So our main aim of this session is to prevent this reactive oxygen species or to prevent that oxygen toxicity. So antioxidant defenses include the enzymes like superoxide dismutase, catalase, and glutathione. So non-enzymatic antioxidants start to cross the placenta in the late gestation and include vitamins A, C, E, and ubiquinone. So premature babies particularly are in risk of oxidative stress injury because they are both the endogenous and passively acquired exogenous antioxidant defense systems are not fully mature. So as we all know, oxygen toxicity results in retinopathy of prematurity, bronchopulmonary dysplasia, necrotizing enterocolitis, intraventricular hemorrhage. These are the common pathology which occurs in the newborn period. And here, just a slide about the fraction of inspired oxygen. 100% oxygen is equal to FiO2 of 1, and each 1 ml per minute flow is increment is equal to 4% of FiO2. So low flow is 21 to 50%, that is 0.21 to 0.5. High flow is 50 to 100, that is 0.5 to 1. So the oxygen delivery method or this system requires, whenever we are delivering oxygen, it requires certain things like source of oxygen, oxygen tubing, flow meters, humidifier, and delivery devices. So we all know that there are two oxygen delivery methods, that is the low flow oxygen delivery system and high flow oxygen delivery system. So some of the examples for low flow devices are like nasal cannula, nasal catheter, a simple nasal, simple oxygen mask, or a partial rebreather mask. And high flow oxygen delivery systems are Venturi mask or high flow nasal oxygen therapy, and the mechanical ventilators, which can include non-invasive or invasive CPAP machines and resuscitation bags. So these are some of the examples of oxygen delivery devices which we use in day-to-day practice, like nasal prongs, which requires 1 to 2 liters per minute of oxygen to be, it delivers 1 to 2 liters per minute of oxygen. Nasal catheter also up 1 to 2 to maximum of 4 liters per minute, and nasopharyngeal catheter same. And simple mask, simple oxygen mask requires at least 5 liters per minute, and a Venturi mask requires 5 to 8 liters per minute, and head box or hood box requires 5 to 10 liters per minute, and CPAP 8 to 10, and ventilator, depending on the condition of the baby, we adjust the oxygen requirement. So we just come to a most important topic, that is the target saturation, which is very important for us so that we can avoid the oxygen toxicity. So here oxygen has been both a vital therapeutic tool and an agent of harm in neonatal care. In 1900, Budin recommended oxygen during episodes of cyanosis, and Hess in 1931 recommended oxygen for infants with apnea, cyanosis, and asphyxia. In 1942, Wilson, Long, and Howard observed that periodic breathing commonly seen in the preterm infants were largely abolished when these babies were given 70% of oxygen or more to breathe. With this level of evidence, there was widespread practice of unrestricted oxygen supplementation for small or sick infants in the early 1950s. A Cochrane review and 2 other studies clearly demonstrated that unrestricted high levels of ambient oxygen could cause severe eye disease in the preterm babies that we all know, retinopathy of prematurity. So in the neonatal period, in term infants or babies who are more than 1.5 kg are not at risk of ROP, as we all know, but hyperoxemia may still compromise the cerebral perfusion and exacerbate the oxidative stress in the especially the presence of HIE, that is the hypoxic ischemic insult. So there are some observational studies that reveal that healthy term infants pulse oximeter saturation ranges from 89 to 100% in the first 24 hours of age and 92 to 100% in the first week of age. In majority of infants, acclimatization to pulse oximeter saturations, that is more than 95% pre or post-ductal, occurs rapidly, taking an average of 12 to 14 minutes in the post-delivery period. So in preterm infants, it's slightly different from the term infants. So a significant body of evidence now suggests regarding the study of pulse oximeter saturation targeting in preterm and extreme preterm infants. Hyperoxemia in the preterm infant is associated with the development of, as we all know, chronic lung disease, CLD, or ROP retinopathy and retinopathy of prematurity, whereas hypoxemia is associated with increased mortality and the development of necrotizing enterocolitis. So in between these two, we need to manage. So there are many studies which have been done and which are still under process. So one of the two common are the POOST and the STOP ROP trial, which provide evidence that targeting saturations more than 95% is deleterious to the preterm infants. So in the oxygen delivery room, we all know, as per the latest guidelines, we are not going to start with the baby with the resuscitation with oxygen with more than 21% oxygen in term babies. We are going to start with the 21% resuscitation, and in preterm babies, around 30 to 40% of oxygen is required to initiate the resuscitation. So this is the oxygen saturation targets, which now we all follow in the NRP. So that is time after delivery, 1 minute after delivery, the pre-ductal saturation is we can expect 60 to 65%, 2 minutes 65 to 70, 3 minutes 70 to 75, 4 minutes 75 to 80, 5 minutes 80 to 85, and more than 10 minutes 85 to 95, which is very important for us to follow this, maintaining this target saturation. So how can we improve the maintenance of oxygen target in our settings? One is increasing the nurse to patient ratio so that they can closely monitor the babies, and setting the pulse oximeter alarm close to the targeted range, training, educating, and motivating the clinical staff, developing unit protocol and specific oxygen titration guidelines, and volume targeting strategy reduces the duration of hypoxemia and time spent on low saturation values as compared to the pressure regulated ventilation. So automated control of FiO2 to episodes of hypoxemia can be done. So there are, as I told, there are many randomized control trials, also called the oxygen trials, which are done, like Boost 1, Boost 2, Canadian oxygen trial, and STOP ROP or support trial. These are some of the studies which have been done for oxygen toxicity and how we can modify the or prevent all this oxygen toxicity, the damages caused by oxygen toxicity. So this is a table which shows the oxygen target saturation and the alarm limits which can be set. So, in preterms which are less than 37 weeks and birth weight of less than 1.5 kg, 1.5 kg, the target saturation can be kept at around 91 to 95%. So we can expect that saturation or tolerate the saturation between 91 to 95%, and the alarm limits can be kept at 90 to 96%. In term infants which are more than 37 weeks, the saturation we can target for more than 95%, and alarm can be set at 94 to 99%. And in preterm infants with corrected gestation more than 37, the target saturation will be more than 93, and the alarm limits can be set at 92 to 99%. So in special situations like babies with PPHN or any cyanotic heart diseases, the target saturation should be more than 95%, and the alarm limits can be kept at 95 to 100%. It's always better to avoid hyperoxia, especially in duct-dependent lesions. So one of the important component of this oxygen delivery system is an oxygen blender, which we all need to bring into practice in most of our institutions where it's still lacking. So the recognition of oxygen toxicity in neonates has led to the clinical guidelines being revised globally. By 2010, the International Resuscitation Councils began advising unregulated administration of pure oxygen for neonatal resuscitation. That is the recent change in the NRP, where we need to use the oxygen blender during resuscitation. So oxygen blending devices which combine pure oxygen with room air to regulate the concentration of oxygen delivered have increasingly been adopted as the standard of care. So this is, as we all know, this is an oxygen air blender, which is commonly used wherever the oxygen air blender is available. Most currently available oxygen blenders are precision engineered valve devices which mix the compressed air and compressed oxygen from high pressure, typically 50 psi sources, and to bring about maximum benefit to premature newborns and neonates in resource limited regions, investments must be made to support the development and implementation of affordable oxygen blending technologies. So because in many of the resource limited nations or countries, this has been a lacking. So it is always, they have to work on this, and it's always better to, we work on this to get this implemented. Oxygen blending is a pillar of effective oxygen therapy and is critically needed to improve the care of millions of newborns globally.
Thank you, Dr. Kavitha. Nice presentation, and you covered most of the important topics. Just a comment, maybe a clarification. The saturation target, can you go back the slide on saturation target for term babies? So even though we say oxygen is relatively safe, I mean, yeah, that slide. So we would like to keep the alarm limit 97 to 98. So don't exceed 98, because as you see the oxygen oxyhemoglobin dissociation curve, above 98 you may enter hyperoxic zone. So, and there is no benefit of giving more than that. So the saturation target of more than 95% can be specified as 97%, and the target alarm limit can be 98%, not 99. And of course, if the baby is in room air, you can keep it 100% if the baby keeps going above, so you don't get unnecessary alarm. So this is one clarification. Apart from that, I think everything was very clear, and the blender part you stressed, and all the more reason that we need in India, especially more and more people are using non-invasive ventilation, and without blender it should not be used, because if you need pressure, you are likely to need some oxygen as well, and if you give unregulated, you have risk of oxygen toxicity. So the ROP risk, I mean, now the guidelines have included less than 2 kilos and less than 34 weeks due to the aggressive posterior ROP. So that is coming up probably because of abuse of oxygen. So without the blender, you cannot. You have the newer systems, as you said, in resource limited settings, the Venturi based systems or the low cost. We have the non-invasive machines coming with blender, so you can use that right from the labor room to the neonatal unit. So you can invest on those if you can't afford a blender separately. The TPs can be connected through that for the mask ventilation as well. So any questions? We have a mic for the audience. Yes, speak in the mic so the online people can.
PPHN also, the we have to keep the oxygen target below 100% because it will cause oxidative damage and will increase PPHN.
Yeah, she mentioned that we should avoid hyperoxia. So hyperoxia can inhibit your nitric oxide system in the lung. So Professor Satyan's research has shown that. So it's better to avoid more than 98% even in PPHN. Even in situations like diaphragmatic hernia, I mean, you are going to minimize the use of ventilation by lowering your targets as well to realistic levels. Any comments or questions?